Hello, and welcome to the Pink Pineapple Podcast, where we peel back femtech and take a bite out of more than just the juicy bits.
I'm Claudia, and I'm Emma's partner in Pineapple for this adventure.
And I'm Emma. Together, we're exploring women's health across the full timeline, from first periods to menopause and everything in between.
Each week, we'll dive into the stories, science, and software shaping the future of women's health. From hormones to hardware, fertility to femtech founders.
Think of us as your slightly nosy best friends who just happen to be doctors with a healthy curiosity for innovation.
We'll be chatting to clinicians, creators, and changemakers. And yes, asking the questions you actually want answered.
So whether you're out for a walk, cooking dinner, or hiding from your to-do list, join us as we get curious, clinical, and occasionally controversial.
This is the Pink Pineapple Podcast,
where women's health meets what's next. Hello, and welcome to another episode of the Pink Pineapple Podcast. And this week, myself and Claudia have got an amazing guest. I'm just going to read a list of her accolades now because I'm completely kind of fangirling over Fran. And she is an obstetrics and gynaecology doctor. She's currently in the clinical training program. She has just completed a PhD with King's College London, I believe, making her a double doctor. And she's a CMO of MEGI Health. I mean, what an introduction. Claudia, you've also
Absolutely.
got another guest that
I've
you're
got an
very
introduction.
to introduce.
I'm just going to bring the level down a little bit for us and just share my very accomplished pineapple of the day. So for those that are viewing, you are fortunate. But let me explain to you what she looks like today. She's got my 8-year-old's really gorgeous blue tinted sunglasses on, but they're in the shape of a heart. So there's a clue for you. And she's got the Queen of Hearts card in the top. What do you think, Emma, of today's attempt?
I think it's much better than you led me to believe. I had worries that we were going to see a disheveled pineapple for what messages.
You know what they say? You set your expectations low and then, people are pleasantly surprised. So yeah, let's crack on.
So Fran, we would love you to introduce yourself and MEGI with people who haven't heard about you before.
Yes, well, thank you so much for the introduction and real pleasure to be here. So I'll talk a little bit about my journey and how that sort of led to my involvement at MEGI Health. So when I was young, I really wanted to be a scientist. So I actually did my undergrad natural sciences at Cambridge and then decided to do medicine as a graduate, did graduate medicine. And I can still remember the day I had a lecture on the placenta and I was like, that's it. Women's health is for me. I've been following a clinical academic path for roughly the past decade. So I did, academic foundation jobs and got an ACF. And through the kind of pockets of research time that I had, was then able to get an MRC fellowship, which was amazing, and complete my PhD. And during my PhD, I've worked on clinical trials, electronic health record data, and genetics, all focused on high blood pressure in pregnancy. I've been thinking a lot about preeclampsia and blood pressure. And one of the things which is really clear to us from the data, but we really fall short in clinical practice, is around understanding that pregnancy is actually really a stress test for your general health. So, for example, women who develop preeclampsia or high blood pressure in pregnancy are much higher risk of developing chronic hypertension, up to 4 times the risk in the postpartum period, higher risk of strokes, but also vascular diseases, vascular dementia, peripheral vascular disease. And unfortunately, because of the constraints of the healthcare system, in terms of funding, in terms of staffing, we don't do very much about this at the moment. And I know you both being mums as well, there is a real cliff postpartum in terms of the care that people receive. And it was serendipity, actually, that I was on LinkedIn and saw that the CEO of MEGI, they just published this preprint about their technology improving blood pressure control in the chronic hypertension space. And I said, is anyone doing this for pregnancy? Because pregnancy is such an important window, pregnancy in the postpartum. And we started talking, and then, a few months later, I started working at MEGI Health, and it's been a really amazing journey. So the what the company does is really focused on women's cardiovascular health, starting in pregnancy. So thinking about both prediction and prevention of preeclampsia and hypertension using AI digital health solutions, working both on the sort of the patient side in terms of engagement and education, as well as data-driven information for clinicians to be able to make easy decisions. And then this seamlessly moves into postpartum support and longer term health. And we've got research going on across the entire spectrum. So pregnancy, postpartum, and then also things like, menopause, cardiovascular health. Got active research projects in all those domains. It's really exciting to be working in a sort of science focused company setting.
So it'd be really helpful, Fran, for our listeners who maybe aren't clued up on preeclampsia, just for you to give a definition of preeclampsia. What is it? Who does it affect? And if there are any risk factors?
Yeah. So what preeclampsia is and the sort of the signs and the symptoms. Yeah. So it's what we would call a complex disease. So it's very one of the words often used is like heterogeneous. So the presentation can be very, very different in different women. And I think that's one of the challenges in studying preeclampsia is that it's probably many different pathophysiological processes that all get lumped under one diagnostic umbrella. One of the distinctions that we've started to make in the past couple of decades from the scientific perspective is pulling out what we call early onset versus late onset preeclampsia. So preeclampsia is generally felt to be a placentally mediated disease, and that's why we say delivery is the cure, because you remove the placenta, so therefore you stop the disease process. Although I have to caveat that with postnatal preeclampsia is a thing, it is completely possible. So there's obviously, whether that's sort of the process has started in pregnancy and then even with delivery of the placenta it continues, or whether we really don't understand preeclampsia well enough to be able to explain these findings. It's important for all clinicians to know and women to know that preeclampsia can occur postnatally. But generally speaking, we think of it as a placental disease. In the early onset form, this is very much felt to be due to early problems with placentation. So if you imagine the womb, when you're not pregnant, you don't want a huge blood supply to your womb, because if you did, you would bleed to death every month. That would not be conducive to survival of the human species. You deliberately don't want a huge blood supply to the womb, so the blood vessels are narrow, they're quite tight, and you don't have a huge amount of blood flowing to the womb. When you're pregnant, obviously that completely changes. So from very early in pregnancy, you need to start supporting the developing fetus. So you need to go from a high resistance, low flow circulation, so think like narrow pipes in a plumbing circuitry, to nice wide pipes, so a low resistance, high flow circulation. And that happens through a process that's called remodeling of the spiral arteries, which are the arteries that feed the majority of the womb. And for some reason, in early onset preeclampsia, this process doesn't develop normally. So you don't get that adaptation to pregnancy, and you stick with a high resistance, low flow circulation. So from the off, the blood supply to the developing fetus isn't there. And so that's why you typically get small babies, very growth restricted babies, and early onset disease, because you never had normality. You never had a physiological sort of placentation process. And that is more rare. The early onset sort of phenotype is not the majority of preeclampsia, but it tends to be more severe. Both the maternal and the infant features tend to be more severe. On the other side, we have sort of the later presentation, late onset preeclampsia. So we typically think of that after 34 weeks. And obviously there's a lot of sort of term preeclampsia. And our thinking here, and the analogy is of a pot-bound placenta. So if you think of your house plant, if you, like me, have not potted them in a while, then their roots are completely entangled, and they're clearly not getting enough nutrients anymore. The soil has been kind of worn out, and they can't continue to grow. And one of the things I often think about in terms of analogy is that, if pregnancy went on forever, every placenta would fail at some point, because there is just a volume of baby that you can no longer sustain with an organ that is, limited by the size of the container that it's in. And it sort of, every placenta's got that expiry date, and some will be sooner and some will be later than others. And so preeclampsia might almost be inevitable if pregnancy went on forever, if that makes sense. And that's that kind of idea of the pot blanc placenta. So you get to a certain point where the placenta is just no longer going to be able to sustain the growing baby. And then you get the same process, which is the placenta becomes stressed, oxidative stress, then you get release into the maternal circulating system, and then you get the endothelial dysfunction. And because it's the blood vessels, primarily the disease, it can affect any organ of the body. So you can get seizures in the brain, you can get kidney failure, you can get liver rupture, liver failure, you get the swelling. So any organ system can be affected in preeclampsia. And that's the kind of the physiological underpinning. In terms of how we define it, so classically it was on the basis of new hypertension and proteinuria. That's the new hypertension is slightly complicated in women who've got chronic hypertension, so then you have to look at other features, and it tends to be obviously sort of a specialist diagnosis. But one of the things that's really changed in the last couple of decades is that we've expanded the definition now so that we recognize that any end organ dysfunction with this new hypertension would be classified as preeclampsia. So it could be proteinuria, but it could also be, liver injury or an acute kidney injury. Obviously, eclampsia, if eclampsia was to occur, so seizures, but also things thinking about the fetal piece. So placental insufficiency, so a very small baby with new hypertension in the mother now makes the diagnosis of preeclampsia in these modern definitions. And we're also starting to use biomarkers. So one of the sort of the breakthroughs in the last decade has been proving that markers such as placental growth factor and soluble FLT are really useful, both for prediction, but also in terms of being able to rule out placental dysfunction. So you can also start to make those decisions on the basis of biomarkers. So that's in terms of the definition. It's much, much broader. So the classic definition is hypertension and proteinuria. So high blood pressure and protein in the wee for people who are non-medical. And then in terms of signs and symptoms, I think one of the things to understand that's really important, both in and outside of pregnancy, is that high blood pressure can be completely silent. So you can have, I've seen this numerous times in my career, women actually come in for something else and we pick up the hypertension. So you don't necessarily have to have symptoms to have preeclampsia. That's important to understand. And actually, one of the reasons we have antenatal care, if you think every time you go to see your midwife or your doctor, you'll have your blood pressure measured and they're dipping your urine. What they're doing is they're screening for preeclampsia at every visit. And that's one of the reasons why we have our schedule of care, is because preeclampsia becomes more common as pregnancy progresses. So we screen you more regularly as pregnancy progresses. And so I think that's one thing that's really important to understand. There don't necessarily have to be symptoms, and you need to get regularly assessed. And there's no, way around that. At the moment, we don't have good enough prediction models to be able to say to anyone, yeah, you're absolutely fine. Don't worry about it. You have to keep testing. You have to keep screening. You have to keep looking for the disease. In terms of symptoms, the classic symptoms are things like headaches, blurred vision, dots in the vision, also right upper quadrant pain, if there's the pain at the top of the tummy on the right hand side related to the liver, and also swelling, particularly of the hands and face. And one of the things that's really tricky is that a lot of these symptoms are general pregnancy symptoms, right? So like swelling, lots of people get swollen in pregnancy. So again, at the moment, we don't have good substitutes for going and getting assessed if you have any of those symptoms, or it's your partner or your cousin and you're like, oh, her face has really changed, it looks really puffy. That is a reason to get checked out. And there's great resources for people who are interested on the Action on Preeclampsia website in the UK, and the Preeclampsia Foundation in the US have got lots of sort of public facing resources for people who want to find out a bit more and have that information at their fingertips.
Great, thank you, Fran. So where does MEGI fit into all of this?
Yeah, wonderful question. MEGI was actually born out of a cardiovascular clinic in Croatia. So a clinic that's treated cardiovascular disease for many, many years. And the challenge the problem they were then trying to solve was to how they could manage these patients as an outpatient. So, they'd save their lives, they'd treat the stroke, the heart attack, whatever it might be, get them on their medication. And then, they get sent home and they might see them again in a year. And So they developed a platform really focusing on engagement, lifestyle changes, and blood pressure management outside of hospital. So it's linking in between those appointments, as well as really helping the clinicians to make good data-driven decisions. So the way that they did that was by building a conversational component for the clients, for the patients. So it was WhatsApp based, and it's 24/7 accessible information, blood pressure check reminders, medication reminders, lifestyle advice, and then they'd pull that information through to dashboards for the clinicians. And that's just been accepted for publication, and that piece of work on, I think, over 5,000 patients in JMIR. And really in the last 9 months, what we've been focusing on is how to use this kind of technology and expand this use case, thinking really about women's health. So for the patients and the clients, what that looks like is conversational support. And so that is Ask Me Anything 24/7. Elements of it are rules based from a safety perspective, and then some elements are LLM based. So you can ask about blood pressure, preeclampsia, pregnancy symptoms. And then on the other side, you've got the healthcare professional facing side, which pulls through symptoms, blood pressures, relevant risk factors, and has all that information really easy for the doctors to make decisions. And then in terms of, so that's the sort of, I guess, the core sort of remote monitoring platform. And then some of the sort of exciting stuff from a science perspective is around prediction. So the way that we currently predict your risk of preeclampsia in the UK is a clinical risk factor based approach. So if you have one high risk factor or two moderate risk factors, we recommend aspirin. And I couch this by saying that we are in the sad position in pregnancy hypertension, as with many pregnancy specific conditions, that there are very few treatments out there. So we have aspirin for prevention, and then for treatment, we have deliver the baby. And maybe blood pressure control is possibly emerging as something that might modify the disease course. But we have no specific disease modifying drugs. So once this develops, that's it. And that is sadly a reflection of the lack of general R&D understanding disease subtypes, compared to fields like cardiovascular oncology, where you have much more personalization. We are miles and miles and miles behind. So, we're waiting for those innovations, and some of those things that hopefully will be coming through in the coming years. But at the moment, all we have really is aspirin, blood pressure control, and delivery. And so the models that we have focus on both prediction in that early phase to help guide aspirin prophylaxis, because we know it's really important for aspirin to be started ideally by 16 weeks. So you want to get that accurate assessment early on. But then throughout your pregnancy journey, so that you can get real time, reviewing of your risk, because risk at the moment is calculated on a static basis. And that matters, I think, in some ways more to patients than it does to doctors, because I think, doctors actually, what can you do with the prediction? You're not going to necessarily change your clinical management, but I think it can really change someone's experience of the disease, because one of the things that we've picked up, particularly in the focus groups, is how traumatic preeclampsia and blood pressure problems are for pregnant women. The diagnosis comes as a shock. Often there's an emergency delivery. All of your birth preferences and plans go completely out of the window. You're then on drugs, sometimes for weeks, sometimes for the rest of your life. And the whole thing is incredibly overwhelming. It's hard to get information at the right time, at the right place. And I think it's also incredibly isolating when your friends might be having normal pregnancies and term deliveries, and you're having a preterm that's on NICU, and everything is completely different. A lot of what we're working on is that piece of how can we support through these complex challenges. And then, talking about that postpartum piece where you get this cliff in both information, advice, support. That's where the technology aims to be seamless, so then going straight into postpartum, what should you be doing with your blood pressure? What is normal? When do you need to seek medical attention? So it's really 24/7 support, education, advice for women, and then linking them to their healthcare professionals. That's the kind of model in the UK. What's interesting, and one of the other challenges that we have, is in the US market, healthcare is structured very differently, and a lot of people actually don't have access to OBGYN or very limited access. So we're also starting to work on kind of community models and thinking who in the community can we help to educate and upskill to support women through these issues. And we're doing quite a lot of work with a training program for doulas at the moment in the US. Because that's another challenge of when you don't actually have skilled healthcare professionals to be able to provide the medical support that you need, what can be done in that context. But yeah, we're still working on that.
Great. And is it all delivered via WhatsApp? Is that right? So is it all through WhatsApp and women interact with the platform and all the answers come using
Yeah,
large language models? There's AI involved as well.
yeah, yeah, exactly. I mean, the one of the things that I think at MEGI we feel really important is to make the tech as easy to use as possible. Because if you don't make it easy to use, so even if you've got, speaking to women who've been doing blood pressure monitoring via their GP, they often have to have a login, and then it's like 7 clicks to be able to put a blood pressure reading in. You're going to lose people at each one of those clicks.
Yeah.
That's the reality. We all
Everyone's
know
got
that.
WhatsApp. Yeah. And
Everyone has
everybody's
got,
got WhatsApp. So
exactly.
yeah.
And so interestingly, in the UK, everyone has WhatsApp. And so that's why we're using the platform. And I think in a lot of
Yeah.
Europe, so we're using the WhatsApp. We're using the WhatsApp. We're using WhatsApp because that's what people use. But in different markets, it can be different. And so we're really aspiring to omni-channel communication, but meeting the person where they are. So the ideal is that you don't have to download something, or if you do have to download something. So in the US, for example, because of HIPAA compliance, we're not allowed to use WhatsApp. It's a single link. So you click on the
Okay.
link and then it's straight away. Because that's really, really important. It's about making this easy and making the information accessible, and not making this a burden. Because if you make it a burden, then it won't be done, and then you're not going to have the benefits of the technology. And I
Yeah.
think it's really important in terms of
That
accessibility
makes
and scalability.
Yeah, for sure. So Fran, is this something that your doctor will, so do you go to your GP or to your midwife appointment or your obstetrician and gynecologist, and they risk assess you and they find that yes, you might be at risk of preeclampsia, and then you are added to this,
Yes,
you're able to use WhatsApp in this way?
it's a great question. So I'm biased. I'm obsessed with blood pressure. I feel like all women should take their blood pressure regularly in pregnancy, but I appreciate that I am biased. Um, so I think it's working slightly differently depending on the use case. So in some big tertiary centers that we're working with, because of primarily of budget constraints as well, of like who do they want to give BP machines to, they are focusing on their at-risk population. So women who are at high risk of hypertension, previous hypertension, chronic hypertensive, those kind of clients, or women who have hypertension. So they might have gestational hypertension. They might even be doing outpatient management of preeclampsia. Some places do that. And so that's sort of that high risk group. But the bottom, we know this from the research, is that even a woman who is assessed as low risk currently, that doesn't mean she's not going to develop a problem. And because of schedules of antenatal care, you go between 4 to 6 weeks between BP checks. It becomes more regular as you get towards the end of pregnancy because we're increasing the vigilance on this. But it still means that problems can really, if you develop a problem a week after your antenatal visit, you might not pick that up for 3 weeks. So there are some settings where actually the clinicians are really interested in getting it out to everyone, but it really depends on what it is you're trying to achieve. So are you trying to look at sort of population sort of screening? Are you focusing on your high risk cases? And so the setup and actually the customization. So, where do alerts go? So for example, the platform will alert if a woman is hypertensive, if a woman is hypotensive on treatment, for example. All of that is built in and can be customized per center. And so each center is slightly different in what they're looking for and how they plan to use it.
Is there the option for the centre to tailor the response as per their protocol? So, for example, if they've got, I know that the definition of preeclampsia is set kind of criteria for mild, moderate, and severe, but if they've got a different pathway in each centre, the response back is the option for them to tailor it on the MEGI platform back to the patient.
Yeah, absolutely. So one of the things that um, we talked about with a couple of sensors, and that I think is quite helpful is, um, what exactly do you want that message to say when someone has got either severe hypertension or hypertension? And for example, we can put the MAU number, the triage number, so that a woman doesn't even have to go looking, what's the number I have to call? It's there. She just clicks on it and she can make that phone call straight away. So that, all of that is what we go through as we're going in the setup process. And so at the moment we're set up in I think 2 sites in the UK, and we're in conversation with another 3. So we know we're an early stage company, so we're still, in the early stages, but these are all the kind of conversations that we have as we're setting up.
And what kind of like positive stories are you hearing? Like what kind of positive things are you hearing from, this actually being in place in these centers?
Yeah, it's been really, I think the feedback on the WhatsApp has been really, really positive and kind of took me by surprise in some ways. I wasn't really sure how was that going to feel, but both in terms of the sort of the active users and the beta testing that we've done through sort of focus groups and Action on Preeclampsia, which have been an amazing charity to work with in terms of sort of co-development. I think being able to have such an easy mode of communication has been really, really meaningful to women. So, as simple as opening up a WhatsApp, which we're all on WhatsApp all the time anyway. I think that's been a really, really strong draw. And it's the same from the clinicians. The clinicians can really see the value in that because some centers, they have tried to set up remote monitoring programs, and they have, for example, this patient can't set up the app on their phone because their phone is old, and just those kind of like tech issues. So I think that accessibility piece and the ability to, for example, put something into a different language, that's just like a little bit of money that's needed to do that. And then you can roll out the whole thing in another language. So from a sort of, so from an equity accessibility perspective, I think there's lots of ways where this is, where technology can really make a difference. That's really, really positive. And I think the other thing that's really important to know is that this engagement is what I call the difference between self-monitoring versus self-management. So there've been quite a few remote blood pressure monitoring trials. And what they found is that if you just give people the ability to measure their blood pressure and give them a device, that doesn't change outcomes. And this is true in the chronic hypertension space as much as it is in pregnancy hypertension. So if you give people the means to measure, that doesn't change outcomes. What needs to happen is self-management. So that means having the support, the education, the resources, the tools, and the access to the right people to be able to do something about that blood pressure. And one of the big studies in pregnancy hypertension, which was the BUMP set of studies, they randomized women at risk of hypertension to remote monitoring or not. And there was no difference in the time to a clinical diagnosis. But when you look at the data, the blood pressure was up over a month before the clinic diagnosis, but clearly people weren't looking at it, or they didn't do something about it. So it's not enough to just measure. We need to empower both the patients and think about how do we make this simple and scalable for the clinical team to actually make a diagnosis and make a decision. So it's not just about
So
measure,
true.
measure, measure. We need to actually work out how to make impact and to change
Yeah.
for something to happen as a result. So that's really what we're
Yeah.
working on.
I mean, it's a bit that speaks so true of so much tech nowadays, of
Mm,
so much tech. We have so much data, loads and loads of data. You can
yeah.
get so much done. And then what do
What?
you do?
Yes. What do you do?
See what it tells you and hope it's the right thing, So yeah, absolutely. I think this does sound really super smart, and you can understand why it would be impactful. And obviously you're also gathering data, right? You're
Yeah.
gathering data that you're able to then research that
Yeah.
data, which obviously there's a massive gap in. There always is a huge gap in women's health research, as we know. So you're able to fill that gap with this, which is
Yes.
great.
Yeah, and I think I sort of s- think about the parallels with diabetes. So, we used to use just finger prick monitoring, but now that we can use continuous glucose monitoring, there's a lot of value to that data. and being able to react in a much more precise way. And I think that's, I mean, this is a discussion we have all the time in research around blood pressure. It's a continuous measure, and we measure it intermittently in clinic. We know that home BP monitoring gives us more information than clinic monitoring, and we know that ambulatory BP monitoring gives us more information than home BP monitoring. So, my expectation is that as we move towards wearables integration, although we're still working on getting you know to know which wearables we might be able to use in pregnancy, because that's always a challenge, making sure that devices are validated for use in pregnancy, and particularly pregnancy hypertension. But I think as we get that granularity, we're going to start to get more mechanistic understanding, more phenotypes. Is our big variations in blood pressure relevant to pathology? Thinking about things like placental abruption, so when the placenta comes away, and thinking about baby size, what are the sort of physiological drivers of bad outcomes, and how might we actually choose medication in a way that might be improve the the actual physiology, as opposed to just treating the blood pressure, which is what we do at the moment. And I've been working on the trial with the amazing Professor Lucy Chappell, who's been my primary supervisor for my PhD, and we still don't know of the two drugs. We will very soon know, but this is what the trial has been answering. But we've used drugs for donkey's years, not because we know that they're the best drug, it's just because it's what we've used. We haven't had the studies yet, but that is coming. So Giant Panda will be publishing in the next 6 to 12 months, which is very exciting. But we just don't have that data.
I think it's so interesting, some of the things that you mentioned there, Fran. I think, like you say, with regards to placental abruption, seeing whether or not there is a pattern, if there are these big swinging shifts in blood pressure, and if there are these massive hypertensive, almost crises before an abruption, it'd be so useful to know that, wouldn't it? And knowing kind of when is the best time to intervene or to offer additional monitoring or hospitalization, etc. I think there's so much scope, isn't there, for learning from the data that you're
Yeah.
collecting. I'd just like to, if we can, just drill down a little bit more into kind of postnatal preeclampsia and life after preeclampsia, because this is something which I think I've mentioned to Pran in previous discussions is a bit of a bugbear of mine. And because we know that, obviously, Fran, you're going to go into this in a bit more detail, but we know that preeclampsia is a huge risk factor for future cardiovascular issues. And I think that often women aren't aware of this after they've delivered their baby, after they've gone home, after they've been, kind of seen by their midwife and they're settled. I feel that not all debriefs and not all follow-up are equivalent. I think that, we're not very good at standardizing the information that we tell patients. So it'd be really helpful to know kind of what your thoughts are on that. And also, is there kind of a way that you see MEGI being involved in this? Because I think that we often treat pregnancy in silos. We treat each pregnancy kind of in a separate kind of box, and we don't think about what we call interpartum health or health between pregnancies. So I'd be really interested from a kind of completely like nerdy obstetrics point of view as to what you think about that.
Yeah, and absolutely, it's such a important topic, and I think we don't do anywhere near what we could do. Although we all know working in the NHS is it's challenging. It's challenging to set up new services and new pathways. So I think one thing is that the data is very, very clear. We actually, myself and a couple of my supervisors, we wrote an editorial last year, I think it was 2020, saying long-term cardiovascular disease after preeclampsia, time to move from epidemiology to action, which was exactly on this topic. It was another systematic review showing the very strong associations between preeclampsia and incident cardiovascular diseases, across the whole spectrum. And we know this now. What the chicken and egg piece of whether it's your pre-existing cardiovascular risk and pregnancy unmasks your risk, or whether there's a sort of hit of preeclampsia itself. We can argue about that till the cows come home, but actually that doesn't change the fact that you are at significantly higher risk. And that risk starts from the postpartum period. It lasts up to 40 years of follow-up. That risk discrepancy is persistent. And I think people think of this happening later in life, but these events happen to women under 40. So this is not actually even, the events themselves are rare. And I think that's part of the challenge, I guess, is maybe the visibility and the prediction is hard because they're rare. But that for that woman and that family, that's completely, if you have a stroke as a young mother, that is completely devastating. And it's not just your life, it's your children's lives as well that has, devastating impact. I think in terms of awareness, I mean, I was talking on this topic in my NHS AI fellowship because some of the models that I'm working on from a research perspective are around this prediction of risk. And I'd say 90% of doctors, so these are obviously very smart clinicians working in clinical AI, 90% of them were like, oh, I had no idea. That's so interesting that pregnancy is a stress test. And you're like, yeah. So I don't think this is common knowledge. That's maybe acceptable for an ENT doctor, but actually someone has done research. And I say someone, Professor Jenny Myers in Manchester has done work on this, and they did a survey and they published it last year. They got responses from over 240 combination of midwives, obstetricians, cardiologists, and GPs. And obstetricians were the most likely to counsel women, but that was still only 40%, 40-ish percent always, 20 something percent so often. And 75% of cardiologists and 62% of GPs never counseled about the risk. So even if they knew, that the knowledge wasn't too bad, and I guess that makes sense that GPs and cardiologists are more likely to know, but actually translating that into, do you actually talk about this and do you take this into account when you're calculating risk? It's not there. And I think that just shows the magnitude of the gap. The most recent American Heart Association guidelines that were released just earlier this year, they have recognized pregnancy hypertension as a risk factor. It's not actually in the kind of Q risk equivalent, but they talk about it being something to take into consideration when you're thinking about risk, which I think is a major step forward and just a lot more focus on pregnancy hypertension than previously, which was really positive to see things moving in the right direction. And I think Q risk 4, which came out a few years ago, the publication, I don't think it's translated. I think it's GPs, you'll know better than me, you're still using Q risk 3. Was it Q risk?
I think we were in my practice before I went on maternity leave.
Yeah. So Q risk 4, they did identify pregnancy hypertension as a sex-specific risk factor for cardiovascular disease as well as postnatal hypertension. But again, I don't think that's made it across yet into clinical practice. So I think there are huge gaps both in terms of knowledge and also clinicians, I guess, having the tools and the confidence to talk about it. But I think part of the challenge is we don't really know what to do. We don't really know what to do. Like, we don't have pathways, and who takes responsibility? Is it the primary care provider? Should it be a cardio obstetric clinic? Should there be dedicated follow-up? Are we thinking that women who are obese, should we be thinking about interpregnancy weight reduction using, medication? So I think there are knowledge gaps and there is lack of confidence, but that's partly because we don't really know what would good management look like. So I think that is an area that needs a lot more research, because one of the things that I think is that I find challenging at the moment is you can say the risk, but then what do you do about it? And it doesn't feel like we've got good pathways. But I think, it'd be interesting to hear from your GP perspective what that might look like. I know I'm talking a lot, but from a MEGI's perspective, absolutely, this is an area that we're really interested in. And one of the reasons why is because good blood pressure control, it's still early, preliminary findings from a research study, but good postpartum blood pressure control in the first 6 weeks in a small study of about 100 women was associated with better blood pressure off medication at 2 years. And it's quite possible that you get this. We talked a bit about the remodeling of the arteries when you become pregnant. There's a reverse remodeling when you are postpartum. So your whole vascular system shifts. That's why you get fluid moving around, you pee a lot, all kinds of things that happen. And your heart that's remodeled to adapt to support pregnancy. So increase in heart rate, increase in cardiac output, muscle mass of the heart changes. That reverse of that has to happen postpartum. So it might be that we're in a window that's more plastic, where actually good cardiovascular management in that postpartum window when you're reshaping your cardiovascular system might have really long lasting health benefits. And if that's the case, that's really exciting to think targeted management in those early weeks, which we could absolutely do through MEGI technology, could have lifelong benefits. That's the kind of evidence you want to see, right? To be able to say, okay, this is where we should be putting time and energy and money.
Yeah. Yeah, that's amazing. That is absolutely fascinating. So basically, watch this space, I
Yes, I
suppose,
think so.
that research,
Yeah.
right? It's very cool.
It just makes you think like the female human body is so
Yeah.
resilient and just so
What it
amazing.
goes through.
Yeah.
Like the changes, you can just look at the postpartum period, well, a pregnancy in general, and just think it's incredible. And I think,
Yeah.
where is the money? We need to be putting
Yes,
more
where's the
investment
money?
into this,
Exactly.
to this,
Where
these,
is the money?
yeah, I mean,
Yeah.
because I was just going to allude to as well, we were talking about Q risk. So for the non-clinicians amongst us, this is a way that we can calculate risk of heart disease, but it's for men and women, the Q risk
Mm.
score. You know, if we're talking about all these risk factors for women, is it time that we get a female specific cardiac risk factor score that we're using in
Yeah.
kind of practice?
Oh, 100%. 100%. I think, it's what get her name, Caroline Criado Perez in Invisible
Yeah,
Women
yeah,
speaks so eloquently to sex disaggregated data. If we just look at women separately from men, and look at the data, clinical trial findings can be quite different. And at the moment, we just haven't done that. We haven't done that. And I think there is, I mean, I think it is, and I say this, and then you look at sort of political climate elsewhere in the world, and you're like, are we progressing? I think there is growing awareness. I think people are starting to take notice. And I think also as women are becoming more economically empowered generally globally, if you think about senior leadership, investment funds. I think 50 years ago, I'm not saying it's great today, but it is better than it was. I'm hoping that as that shift continues to occur, we start to get more money in, because as you say, without the funding to do the basic research, to do the mechanistic, the pathophysiology, and then high quality clinical trials, we're still left in pretty muddy waters for a lot of this.
yeah, definitely. I would just like to, I think I'll probably get in trouble, Fran, from some of our listeners if I don't ask you about your AI fellowship. Because they'll
Yeah,
probably, somebody will have been listening and thought, how has she got on that? How can I get on that? Tell me more about
yeah,
it. So I better make sure
yeah, yeah, yeah.
I ask you that before we wrap up soon.
Yeah, of course. So it's a brilliant scheme. I'm in cohort 4, and each cohort has been expanding. And the focus of the scheme is really about implementation of AI. And the reason being that several reviews, I think the Topple review, NHS Workforce Planning, have identified obviously AI technology has the potential to solve many problems in the NHS to make things more efficient, and that the bottleneck is not in the technology, the bottleneck is in implementation. And there's a whole host of complex reasons why that is. But one of the solutions that's been put forward, and that's why this program is kind of the flagship of that, is having clinicians that can sort of sit across those worlds. So you can speak to the developers, the tech people, your clinical stakeholders, understand the problem, and actually both create and push things through that work and that are going to add value to the healthcare system. Because I think a lot of what, and not so much people like me, but my bosses, people who are very senior positions, they get a lot of solutions thrown at them that clearly have been developed without a specific problem or without the stakeholders in mind. And one of the things that sort of, and it's sort of, I guess it's being led by the tech rather than being led by the clinical problem. So like one thing that always comes to my mind is 80% of AI solutions are radiology based. 80% of problems in the NHS and clinical medicine are not radiology based, and that's the disparity, right? So it's about trying to upskill clinicians to have that agility to work with really different groups of individuals in terms of job roles to both create, design, and implement solutions that work in a safe way to the benefit of the NHS. So yeah, it's a brilliant scheme. It's an amazing network, just being in the same room with 40 other doctors who are interested in AI across different specialties, learning from some specialties that are way more advanced in AI than my specialty has been really, really great. So yeah, started in August. It's a 1-year program. They will fund up to 40% full-time equivalent recharge to your clinical employer. So you need to be able to take time off to do it. I think you apply directly through the AI fellowship website. So yeah, for anyone interested in AI, and I don't think you have to have AI experience. So it's really there to upskill people. So don't have imposter syndrome. I think, oh, I haven't done that, so I can't do that. Anything to do with digital, anything to do with transformation, even quality improvement, it's all really relevant experience, because a lot of this is not about the tech. It's about how do you get through the processes to actually get some AI technology into live clinical workflow.
I'm sure that website will kind of suddenly have an increase in its hits once this airs and people are thinking about applying. Thank you so much, Fran. Today has been so interesting. And I think the information that you gave about preeclampsia, I think was so comprehensive and really interesting. And I'm sure there'll probably be some people that maybe have been diagnosed with preeclampsia in the past that listen to that and think that's maybe the most information that they've had since they were diagnosed. So I think, that we're really grateful for that. Where can people learn more about MEGI, and where can they learn more about you as well?
Yes, of course. So MEGI is on LinkedIn and on MEGI Health on LinkedIn, and we have a website www.megi, which is MEGI.ai. Then I'm on LinkedIn, Fran Conti-Ramsden. That's probably the best place to find me. Actually, I think I don't have my own website or anything like that. And yeah, I have. If you're a guy in St Thomas's, you'll see me on labour ward and gynaecology and the PAGI. So yeah, you can find me there. And then my academic home is at King's College. Yeah, so those are the places to find me.
Fantastic.
Great.
I'm sure you'll be a professor at some point, Fran. I've got no doubt.
One step at a time. I'm recovering from my
professor in a week.
I need more time. Yeah. No, it's been a real pleasure to chat to you both. Thank you.
Thank you. Thanks for being here. We love having you with us on this journey through women's health and innovation.
Follow us on Instagram at the Pink Pineapple Podcast for clips, conversations, and the latest in women's health and femtech.
We'll see you next week. Same pineapple, new topic. Everything we talk about on the Pink Pineapple Podcast is here to inform and inspire, but it's not a substitute for professional medical advice. If you're worried about your health, please reach out to your GP or healthcare provider.